I want to welcome everybody to Empowered By in our fourth episode, which is MS and hormones. And I'm going to start by introducing our awesome expert, who is Dr. Riley Bove, who is right below me in our Brady Bunch format. Dr. Bove is a clinician and researcher at the University of San Francisco. She is spent her time researching MS and hormones, and specifically is looking into hormonal modulation in terms of whether or not that can better a person's health and maybe even better their neurological abilities, which will be really interesting to speak about. Also, she is looking into the idea of gender-specific treatment, which makes a lot of sense in the spirit of people living with MS, and that 2/3 of them are women. Also with us is Sheila Crowley.
Good morning.
Hi. Also with us is Sheila Crowley, who is our featured guest. She's a My Counterpain MS user. She also is a dear friend of mine. We found each other through MS, and Sheila has had MS for a long time and went for 23 years without a relapse, and then had a relapse, and it coincided with the onset of menopause. Is this a coincidence? To be discussed in some degree on this webcast. So we're going to kick this off actually with a video, kind of a hormone 101 for getting an idea of what hormones are about. And then Dr. Bove, maybe you can comment on it in terms of what you see.
Many of the body's most basic functions are regulated by the endocrine system, 8 different glands located throughout the body. The endocrine system constantly and quietly does its work, secreting liquid chemical messengers called hormones. These chemicals manage muscle growth and digestion, as well as energy, reproduction, and more. Here in the pancreas, a hormone called insulin is produced and secreted into the blood. When levels of blood glucose or sugar become too high, the pancreas increases production of insulin. Chemicals in the insulin cause body cells to open up, allowing more glucose from the blood to enter cells, stabilizing the amount of glucose in the blood and maintaining adequate energy in the cells. This is just one example of how the endocrine system regulates a number of important body functions.
Dr. Bove, talk to us. How did that sound to you in light of giving a 101 on hormones?
I think that's a great introduction. I think the fascinating thing about hormones is they are these little messengers that carry signals about the outside world, whether it's sunny or cold, whether someone is your friend or threatening to you, what you've eaten today, and how other body parts are doing internally. And they carry all those messages around to all the body parts that need to respond. And so they're really interesting molecules with a lot of personality. And I think today we're going to focus on the gonadal hormones. Those are the hormones that regulate reproduction. Other hormones that have been really investigated in terms of MS are hormones that regulate cortisol and stress responses, and then also that regulate sleep-wake cycles and melatonin and things like that. But today we'll focus on the gonadal hormones.
What's interesting to me is the endocrine system is different in when you think about MS, you think about it as being a neurological condition. And here is this whole other system. So talk to me a little bit about how they can intersect.
Yeah. So from the prenatal environment all the way to aging, the hormones regulate brain. So they regulate brain development. They do regulate some differences in structure or in function between men and women. They regulate development at different phases. So in the prenatal phase versus the neonatal versus puberty, hormones are doing specific things to the brains of girls and boys to help them develop towards the adult brain. One of the really interesting periods is during pregnancy. You see a lot of changes in the brain. You see the pituitary, which sort of regulates this whole hormonal cycle. You see the pituitary plump right up and start, generating production of things like oxytocin, things that really serve to prepare the maternal brain and the maternal body for pregnancy and breastfeeding. So we see hormonal signaling do a lot of things throughout life in the brain.
You know, it's funny, I think that in the world of MS and hormones, the place where the correlation between the two of them have gotten the most media attention is pregnancy and MS. Can you tell me why that is, and what's happening in that realm?
Yeah, so this is sort of one of the classic hormone brain scenarios, and it's a scenario that was observed for a long time by women with MS and then by their nurses. And eventually in the 80s and 90s, this percolated to the medical literature and became one of sort of the best known graphs, where you have the risk of relapses for an individual woman really seems to decline during pregnancy, especially towards the end of pregnancy in the 3rd trimester. And then once the baby is delivered, you can see a spike in the risk of relapses before the risk of relapses returns to that woman's baseline. And that's an observation that's been really reproduced time and time again, and it seems to be one of the sort of strongest ones.
Has it clinically been shown to be true, Dr. Bove, that there is a decrease of relapses in pregnancy?
Yes. Yes. Yep. That doesn't mean that some women won't relapse, but it means that on the aggregate, the risk of relapses declines significantly. And it brings in a lot of questions about what are the hormonal mechanisms for that? Are the hormones doing something directly to the brain, or are they doing something to the immunology, and that's affecting how the immune system interacts with the brain? We know that in pregnancy in general, it's sort of an immunotolerant state, meaning changes to the immune system have to happen so that the mother can tolerate a fetus. The fetus, you know, half of its genes are not the mom's, and so to prevent rejection of the fetus, to prevent rejection of all of this other stuff that's coming from another organism, the immune system does have to adapt and become sort of relatively immunotolerant. So probably a lot of those immune changes are also impacting the body's response to the brain and the body's tendency to attack the myelin.
But on top of that, certainly, you know, and I've heard this over and over again, of the wonderful period of pregnancy where there are no symptoms and everyone feels great. And then suddenly there's a sucker punch that comes post-pregnancy. Can you talk about that?
Yeah, so I think there's a couple things to the sucker punch. One is, you know, after every pregnancy, there is a risk of the postpartum depression or postpartum blues or some variant of that. And if you have women with MS who have a higher likelihood of having depression in general, that can be a tough time. Research is done about that, and that's something that my colleagues and I are actively looking at. The other piece is as the fetus is delivered, as the baby is born, then the immune system sort of its immunotolerant state shifts back towards being more heightened. And so does that shift in the immune system actually trigger a postpartum relapse? And so clinically, it's been shown time and time again that there is a risk of postpartum relapses and a higher risk of postpartum relapses, that those can lead women to accumulate disability, and that maybe breastfeeding staves that off or prevents it. And particularly exclusive breastfeeding. So when the baby is not getting any other milk products or any other food. Yeah. And then finally, postpartum, the mom is now caring for her baby and herself. You know, everyone's attentions might be focused on the baby. And so and there's not enough sleep, right? And there's more needs on the mom, and maybe she's not getting the time that she needs during the day to just sort of recover and to rest adequately.
Huh. So Sheila, you are a mother of two. You also have been living with MS for a long time. And I would love for you to give a little background, first of all, about your diagnosis and how you've been. And then I want to know about your world with kids, whether there was anything hormonal for you in this stage of your life.
So yeah, I'm a 54-year-old woman, and I was diagnosed when I was 30, which is not untypical, or at the 30 mark. And that year, I just had a horrible year. I had like a stroke-like effect on my left side, and got the diagnosis that I had MS, and sort of for a year recovered from that.
Physically and psychologically?
Yes, absolutely. But it was very, very traumatic when I didn't actually believe I would come back to baseline, but fortunately I did. And, it's been a long time, but I would say within a year and a half, I was back to myself. And I had 2 children, one at 37 and one at 39. And my sister would say that after my second child, I had a little bit of a bump, but I don't remember it at all. And I do remember that euphoria of pregnancy. I had the best pregnancies, felt the best I've ever felt. And then was, because I had no activity, my neurologist said that, MS is defined by activity, so there's no reason to go on an immunosuppressant right at the time. So I lived happily for 23 years and saw my neurologist once a year, and we hugged each other and everything was well. Until 2 years ago, in the middle of the summer, hot day with a lot of stress and true menopause, like I was deep in, I had what they called an acute relapse.
So before we dive into your world of menopause,
yeah,
which sounds like there's a lot of sweat involved, I do want to ask you, Dr. Bove, in the world of pregnancy, I mean, it's great to hear that Sheila had that amazing, I mean, I feel like I see tons of women who say, oh my gosh, pregnancy was the best with my MS. It felt so great. Is there anything happening on the research side where they're trying to put that beautiful bundle of, hormonal joy into a pill?
Yeah. So that's actually exactly what's been done. 2 separate groups. So a French group looked at the hormone progesterone, which is the hormone that sort of regulates the mom's ability to keep the uterine lining, okay, so that you're then developing the placenta and everything else during pregnancy. So one group looked at progesterone and to see whether that affected postpartum relapses. And then another group out of UCLA, Dr. Rhonda Voskuil's group, looked at the hormone estriol, which is one of the estrogens, and it's one of the estrogens that's dramatically increased during pregnancy. And so they have been giving estriol to women with MS who are not pregnant to see whether that can affect relapse rate. They did report a modest effect recently, actually, in Lancet Neurology. And I think there are questions: how long can a woman stay on estriol if she's not pregnant? What happens if you stop?
For health reasons, that maybe there's a problem to stay on.
Yeah, it is considered one of the safest of the estrogens, but that said, it still does carry risk. And so that's, I think the follow-up studies are looking at estriol specifically in brain thinking and so forth. So not just looking at the feeling of euphoria or well-being, but what else can estriol do that's relevant to MS? So those are the 2 sets of studies so far that have tried to put some of the pregnancy hormones in a pill back into a non-pregnant women. And I think that there are so many things going on in pregnancy that, yes, the hormones are sort of driving a lot of this, but then the secondary effects on the immune system are really going to be key. A lot of research has to be done to follow women during their pregnancies and getting levels of various markers, and also looking at MRIs. My colleagues at the Brigham and Women's Hospital have been looking at brain MRIs before, during, and after pregnancy to see if we see changes in MS lesions. And so that work should be coming out in the next few months. So there are a lot of pieces that are under active study.
Awesome. So Sheila, let's go back to your story in terms of the menopause and what happened, and what did you try to do about it in light of having a relapse in your menopause?
So interestingly, I think I told you this, Kate, but I had, in anticipation of menopause, I had talked to my doctor about it, and he said, this is the next, kind of marker. Let's be sure you get on some kind of hormone replacement when you stop menstruating. And there was this combination of, I hadn't stopped menstruating, and I was waiting for my next year appointment, and I went to and he said, I go to your gynecologist and ask him to prescribe, give him the cue up that you're going to need this medication. And when I went to my gynecologist, I didn't know at the time, but he was really, I don't think he would, he didn't give over hormone replacement lightly, right? So he said, I think if your neurologist wants you to be on this medication, he should give him the prescription. So it's sort of like ping-ponging back and forth, and I was still menstruating. So by the time I got to my doctor, and I was so sick, sort of the first thing he said to me was, Sheila, your hormone replacement, and he's, like this sort of laser message. And I thought, oh my God.
Like, where is it?
Like why is it not with, why is it not part of your regimen?
Why hasn't it started?
Why hasn't it started? And I think I had just ended my period at that point, so it was sort of this gray area. Like, I just ended my period. I knew I was going to see my doctor in 2 months. So, right, we would have had it.
This seems like a very normal scenario of trying to get it together as somebody who's juggling as a woman anyway. I'm just throwing that out there of, starting with one thing, bouncing this way, getting distracted, thinking it's okay. I think this is very normal. So
also not having had anything, the usual markers related to pregnancy that would make me acutely fearful that menopause would do something. Do you know what I mean? I thought, like, these are the three things, you have 2 children and you go through menopause and then it's done. I don't think I took it as seriously as I probably should have, because I'd had no other reason to, right? So, so anyway, so soon, immediately after that, actually, my doctor put me on estriol. I went through a whole testing period, and some people are very, very sensitive to it. It doesn't work for everybody. And very quickly I had like breakthrough bleeding when my period was over. And so they very quickly took me off, so I felt like I was I think I was in one of the studies, and you had to get a lot of sort of write-out or permission to do it. So then I went on an estrogen and progesterone, what's it called? I don't know how you
cocktail?
A cocktail. Yes, an oral cocktail that honestly made things so much better, because I was really struggling with hot flashes, and I was so sick. So the combination of the two was just horrible, and it was the middle of the summer. So I just felt this enormous relief right away, which many women do. Even if they don't have MS, they just feel incredible relief. And then most recently, I have a sister who was just diagnosed with breast cancer, and it was an estrogen-driven tumor. So I went back to my gynecologist and, learned that I really shouldn't be on the oral version, but I should be on a patch version, so it doesn't go into my entire blood system. Maybe you could talk about that, Doctor. I would be so grateful to hear the difference. So now I'm on a patch of a very low dose of estrogen that I change twice a week, and also progesterone, like 100 milligrams of progesterone.
So before you step in, Doctor, I want to ask you to kind of set the scene of people dealing with menopause with MS. Is it something that when they go in at menopause, is this something that they need to go to their neurologist about? I mean, this is a very specific case that's fascinating, but can you kind of set the scene on that?
Yeah, I think I want to echo what you said, Kate, about just sort of women juggling so many things. And I think that menopause is like such a perfect illustration of that. So to give you some perspective on your question, when I have patients come in who are in the menopausal period, and what I hear really frequently is, I can't keep it all together. Something has to give. I'm falling apart. And it's a time period where there are hormonal changes, and we'll talk about those in a minute. There's also empty nest syndrome. There's also, is my career what I want it to be? Is my marriage what I want it to be? Am I, fulfilling my own goals in life? And then there's just sort of body aging you know, everybody experiences. And finally, there's all of the considerations about MS itself. And so previously, in the era before disease-modifying therapies, what was observed is that around the age of 45 or 50, everybody seems to develop a bit more progression. So if you have people who were not treated and who are progressing, then menopause is really just sort of like a little blip on the radar, because people weren't entering menopause and really, you know, with a good neurologic status. And now that we have women who were treated really early and who are followed really carefully, you know, menopause actually is a thing for them, whereas what really wasn't before, because their MS was so much worse than it is today.
But is it a thing for the patient, or is it a thing for the doctor? So if you've been treated for a long time by a neurologist and he's watching you progress through age, is this something he's looking out for?
Not yet. Not yet. And this is something that we really want to bring to the attention of patients and doctors. Neurology notes typically don't mention anything about menopause. So now I'll bring in a little bit of information about MS and menopause. So it does look like ovarian aging. So as the ovaries stop producing estrogen and as they stop, you know, releasing the eggs, as the ovaries age, it does look like there is an acceleration of changes in the brain, and that's been observed in healthy women. It's been observed in women who have their ovaries removed early, so who undergo early surgical menopause. We see long-term effects on brain function in those women in observational studies. When I started hearing from my patients that they felt like something was going on at menopause, we looked in cohorts of women who were followed over long periods of time, and it did look like around the time of their menopause, their MS got a little bit worse. We're not talking major jumps, we're just talking that seemed to be a bit of an inflection, okay? And a little bit of the rates of normal changes seem to be sped up a little bit. And so that looks to be maybe something that really has to do with what's going on in the brain. But then there are many other things that are going on in not only the life of women with MS, but also the body. So that brings in the overlap symptoms, sort of a loose term to describe the fact that menopause has effects on women's mood, women's bladders. Women can have sort of tingling at that time, a lot of things that overlap with MS symptoms, right? And so then you have both sets of symptoms coming together, and when your bladder isn't working quite right, you really need help figuring out if it's because of your MS, because of your menopause, or both, if there's a synergistic effect. So those are the overlap symptoms, and then there's also the hot flashes themselves. So people with MS describe what's known as the Uthas phenomenon, where when you get hot, when you're running, when you're in the hot shower, when it's summer, all of your symptoms seem to get worse. And that probably has something to do with heat affecting the way that your nerves conduct signals. And so hot flashes seem to be a case where that's sort of like Uthas with, like, you know, a vengeance, and it seems to make all of women's MS symptoms kind of flare up. And so I think that's where the question of how to tackle those, whether through hormonal therapy or through other medicines, can really play a role in helping women through that menopausal period.
Can doctors or neurologists actually, at this point, tell the difference between symptoms that fall in both types of conditions? Are you able to discriminate whether something is MS related or something is menopause related at this point?
We should be. It takes a little detective work. So sometimes in the case of bladder, for instance, you can do various bladder tests to see whether the pattern seems to be more of a menopausal one or more of an MS one. And even within MS, it's not just, you also have to distinguish whether the woman has had a relapse, where she has an acute change in her bladder function, or whether previous changes seem to be just kind of getting worse. And so whether she's had a relapse or a bit of progression, and then also whether the symptoms from MS or menopause. So sometimes we do have to do a bit of detective work and call in the help of urologists, urogynecologists, people like that. Sometimes we can't quite distinguish it when we're talking about something like mood.
Right.
Mood, fatigue, that's harder. And then I really see it sort of as a ball of yarn. You have all of your MS symptoms, your menopausal symptoms, your life, and it all kind of collides at this time. And it seems sort of ominous that all of this is happening, but actually we really can start picking apart the different pieces. And it is kind of a time to take, to just think about life in general, and to start planning, to take steps to improve quality of life, and to improve function, and to improve mood, and sort of to help women guide them to the next phase.
One of the things that's been really impressive to me in terms of getting to know researchers and research as a whole is how much the world of MS, we all know, is doing so great with disease-modifying therapies, how they're working towards progressive MS, but really diving deep into things like symptoms. So I know that one of our previous interviews was with Adam Kaplan from Johns Hopkins, who specializes in MS and depression, talking about the fact that in the case of MS, that depression actually sometimes can be a symptom of MS. It's not I'm depressed because of MS. So that whole idea of really beginning to embrace things that are happening to you for different reasons. The other thing that's so wonderful to hear is the holistic perspective that you take with your patients, right? And one of the things, Corin, my producer, who's behind the scenes, we actually had a great time. We went online and we found a couple memes about hormones, and maybe Corin, you can put one or two up of this kind of, blow off about hormones, right? About what they are, and women are crazy, and that's the way it is. And the fact is that they get a bad rap.
Yeah.
So, Sheila, maybe from your perspective, you could talk about what it's been like for you to have this hormonal, that's hilarious. And now we can take that off because it's not true. Sheila, talk to me from your perspective about what it's been like for you to have this kind of hormonal undertone to this progression.
Well, I will just say that, I had an enormous wake-up call, right? And I think what happened to Dr. Bove's kind of thought or thinking is that I really had to take control of my care, which I know a lot of MS patients do. I was, called to arms. And I knew very quickly, as I mentioned, I was desperate to get into that estradiol trial. I really knew that my hormones were wreaking havoc on my situation, making everything worse, depression, you name it.
You felt it intrinsically, like your life was unfolding in a way you couldn't even explain.
Exactly. And so, I ended up at a naturopath who was also part of my doctor's practice. I went directly to my GP and I said I needed an antidepressant. I was, I just had to lift the car. It would inflate the tire so the car could go forward because the car was not going forward. So I did sort of a multi, approach to this very, crisis situation. And I would say now, it was so traumatic. I mean, I had to leave my job. It's a big, big deal. I would say I'm a very big proponent now of this very low dosage of hormone replacement, only because I can see it has helped my mental faculty. It's helped my depression, certainly. It's absolutely helped my hot flashes and my quality of sleep. I mean, sleep alone is just so critical for our brain and everything that we do. And for those women who are in the middle of the night for 3 hours, just sweating and, sad, and, how does that make you the next day? And when you're not well, you have to have an army, behind you as part of your arsenal to keep you, well slept, well fed, and to the extent that you can balance hormones.
Well, the irony is that there's something to be said about feeling better physically, and then the strength of feeling better emotionally.
Yeah.
And what seems really unfair to me, and maybe you can respond to this, Dr. Bove, is that hormones basically take over your emotions on some level. They have some real negative effects, but they also have some positive ones.
Mm-hmm. Yeah. So I think, again, this period is such a period of fluctuation and change. I do tell my patients a lot that, you know, as we start untangling all that ball of stuff, we do get to a point where things settle down on the other side, and where they do feel better and they do feel more in control, both of their medical care and of their health and lives. And so sometimes the hormone therapy itself can play a role, especially with the hot flashes. There are other medicines that work for hot flashes. So if people don't want to incur the risks of a hormone therapy, so for instance, if there is a family history or a personal history of breast cancer, or ovarian cancer, or there's a concern about stroke, things like that, the hormones may not be the right thing for that woman, because you're balancing risks and risks and benefits of many things. But
what are some other risks, Dr. Bove? I just wanted, besides the correlation with cancer.
Yeah, so there's the main ones are cancer, and then also stroke, and there's a concern about sort of stroke, heart disease, cardiovascular disease. And there are also benefits for osteoporosis, which is something that women with MS, especially if they've been more immobile and if they've been treated with a lot of steroids, they may be particularly susceptible to osteoporosis. And that's where some hormonal therapies actually really can be helpful. Hormone therapy can have a lot of strong benefits and a lot of strong risks, and that's really a decision, I do think, that involving not only the neurologist but also the primary care provider to really disentangle the risks and benefits is very important. Not enough is known in the literature already about how hormone therapy affects menopausal women with MS. That said, whether the answer is with hormonal therapy or with some SSRIs, sort of antidepressants, those also have been shown to be effective against hot flashes. And so there are solutions to each of these symptoms and each of these problems. Perhaps that involves hormones, but perhaps it doesn't. But the key is enlisting, like you said, the army, Sheila, like enlisting the providers and thinking about this together. And we've really been advocating. So at the University of California, San Francisco, where I am, we are training fellows to manage women during pregnancy and during menopause, to ask about all these things. And asking about them helps you make your problem list and then sort of tackle specific parts of the problem list and get the answers that you need for that person.
Is that unusual thinking, Dr. Bove? Because I do feel it, you know, from my impression, and please correct me if I'm wrong, there has been a real clinical way of thinking. And because a lot of the holistic stuff isn't proven per se, it's gotten less attention. Obviously, UCSF is known to be quite progressive and deeply invested in the holistic well-being of their patients. But can you talk about being in the space on whether people who are watching today all over the country should expect to find that type of thinking in their own practice?
I think that it's something that the field needs to move towards. I don't think that that's typically part of an MS care visit. And there's a lot to do at an MS care visit. Talk about the drugs, their side effects, monitor labs, review the MRI, talk about spasticity. There's a lot of things. But I think that considering the hormonal transition should be one of those things. And so we're trying to train our fellows, and we've written a few papers about this, and we hope that, you know, with more research and more groups becoming involved in research, you know, research that says that this is a concern for our patients, that this is a quality of life issue for our patients, and that there are important scientific research questions around this that haven't been fully answered. I think that as all of that comes in the literature and at scientific meetings, I hope that it'll trickle down to the providers. On the other, just bear in mind that those providers aren't trained necessarily in the modern considerations regarding, menopause and hormone therapy. These are providers who might have trained a while ago, before the landmark Women's Health Initiative, which was the big hormone therapy study, for instance. So I think that on the flip side of that is sort of, Kate, what you've been doing so well here is getting patients to be informed, empowered, and then to go out and ask providers. And if it comes both from the scientific arena and from the patients, then I think that we'll see a change in the way care is delivered.
Mm-hmm. I want to ask a question that came up. Cindy who's one of the people watching this live, wants to know if hormone therapy is good for women who are postmenopausal.
Mm-hmm. Cindy, that's a great question, and one that we're looking to answer, and that's not known yet. Hormone therapy for women who are postmenopausal. So there's thought that you should really be taking hormone therapy around the time of menopause. So about within 5 years of menopause. That starting it after that may actually be dangerous. In women who are starting hormone therapy within sort of the window of menopause, there are good effects on bones. There may be good effects on mood. And so those are things that are really important to all women and to women with MS. It isn't known whether hormone therapy makes a difference for the course of MS itself.
Mm-hmm. Sheila, let's talk just, we're kind of going to wrap up here, but I want to just get your opinion in light of somebody who lived arguably a really tough experience in terms of A, having a relapse right after 23 years, and B, feeling hormonally awful. What have been the positives that have come out of this experience for you?
What are the positives? Well, I think it's actually along the line of, being the CEO of your care, and really, you were talking about, I have a neurologist, Dr. Sadiq, who, he has so many things going on in his center, that speak to, he has the naturopath, he has PT, he has all kinds of ways that patients can feel taken care of and happy, but there is still that disconnect between him and my gynecologist, that story I just told you, and my GP. So I guess what I see now, kind of 30,000 feet up, is that I really did take control of my own, health, and I'm continuing to. So we talked about, hormone replacement, and I hear this thing around cancer, but I also look very closely at the risk factor and the number of years and the dosage, and there's nuance in all of this, and so to be your own researcher is still the order of the day. And to the extent that, like what Kate's up to, that's why I love you, Kate, so deeply. This is amazing, right? That I get to be on a webcast with the authority in this area. So I guess my lessons learned or takeaways is seek information, keep seeking.
And doctors are not, from your perspective, when you have an educated patient come to you, Dr. Bove, how does that make you feel? I would argue that would be a positive. Is that true?
Yeah, I love it. I from day one encourage my patients to read more about what's going on from informed sites. So the National MS Society, has a great site. And then I also direct them to literature more specific to what's going on with them. I think that the opportunity of getting to a better place is so much greater when patients are involved and informed and participate. It's really discouraging when you give a patient sort of your professional opinion and they're not invested in either, researching it more or care or following it. I want my patients to be part of this, and I recognize that it's not just for me, but our healthcare system is incredibly confusing, you know, and patients need to be the CEOs of their own health. And it's hard when you have MS and you're trying to process all kinds of information and keep tabs on all kinds of medical appointments and providers and drugs and everything else. It's really hard. So I want my patients to be as empowered in that process as they can be, so that we're not, you know, not dropping the ball anywhere. Yeah. And what has been seen is that you know, as women's level of disability increases, they're often less likely to do basic medical checkups. So maybe they're less likely to be getting their mammograms or pap smears or bone density scans or whatever else is indicated for them. These are the people who are managing the most comorbidities and the most stuff, and they kind of drop off the wagon of regular healthcare. And so I think it's fantastic when patients come in, you know, as partners in their own care.
So for you, as somebody who is spending time as a clinician, getting these patients to be their own advocates and really helping them holistically, you're also spending time researching in the field of MS and hormones. And I'd love for you to, tell me what you're excited about in that field in light of what you see and what you're learning. And also for the women, and maybe there are men here too, which is awesome. For everybody that's on this webcast, what would you tell them? What advice would you give if they're kind of having this curiosity about their MS and hormones and how they might be conflicting?
So the research that we're doing, the thing that I'm most excited about is the potential for drugs called SERMs, selective estrogen receptor modulators. And so there are many SERMs on the market that are indicated to do things like osteoporosis. Tamoxifen, which is a drug that's given in certain kinds of breast cancer, is a SERM. And what SERMs do is they tackle some estrogen receptors, so they can heighten the good effects of estrogen and maybe not do the bad effects of estrogen. And so it's sort of like the rose without its thorns. That's the idea behind SERMs. And so we have a pilot trial right now of SERMs for menopausal women with MS, because we want to see if it does improve their mood and quality of life and things like that. And then whether that could be something that we can expand further. For men, we've done a little work looking at testosterone levels and men's MS, and a lot more work needs to be done in that arena. And again, I want to highlight the fact that Dr. Rhonda Voskuil at UCLA has really been a pioneer in getting people interested in this line of research.
She's the one that's really working within the pregnancy realm.
Estriol, and she's also done a small pilot study of testosterone. There's a lot more that needs to be understood and done in that arena as well. And then I think the key is really, this is very personalized, and the person has to be invested and involved as well, and recognizing that neurologists may not always be the best trained people to answer these questions. So I'm certainly happy to get any questions off air from any of the participants today, but also we hope that we'll continue publishing in this arena and sort of making a difference.
The irony too is I think that there's something intrinsic. Again, I know hormones are tied to emotion, but there is something intrinsic also of a woman, and they talk about, you know, trusting your gut, feeling like something's off. And that maybe another takeaway here is that, you know, if you do feel like hormones are affecting you, that may be so. And it's okay to believe that and talk about it.
Yep. And then on a practical note, I'd say, you know, when you're getting around the time of menopause, one practical thing that people can do is to have more frequent appointments with their neurologist. Because even if the neurologist isn't totally skilled at this or trained at this, maybe if you see them more frequently every few months as opposed to every 6 or 12 months, you can just kind of disentangle things a bit better and have time to go see the OB and come back, you know, go see the other expert and come back, and kind of really try to take control of those symptoms and of the quality of life. And so even if, you know, they don't know everything at the first visit, maybe just trying to schedule more frequent visits at that time can really improve care.
Awesome, you guys. Well, this has been an amazing webcast. I want to thank both Sheila Crowley for opening up about a sensitive topic, arguably, and Dr. Riley Bove from the University of California, San Francisco, telling us about the world of MS and hormones. This is Kate Milliken signing off, and we will see you next time. Thanks, everybody.
Thank you.
Bye. Thank you.